publicly funded healthcare system. I think the issues that we're facing is how do we get drug to patients faster, and I can see that the government now in Ontario, and I think internationally, is really focusing on trying to get the approvals expedited and to get drugs to patients, even perhaps while negotiations are still occurring. And I think that's the biggest issue.
Hello everyone, my name is Kevin Bambry and I welcome you to another episode of Oncology Spotlight. Thank you for tuning in. I'm joined today by my co-host Ono Carl.
Hi everyone.
Our guest for this episode is Dr. Shaqil Kassam, who is a medical oncologist at the Stronach Regional Cancer Centre in Canada. Thank you for joining us today, Dr. Shaqil Kassam.
Thank you for having me. It's a pleasure to be with you.
And just to kick things off, could you please provide a brief overview of your professional background and a bit of a personal introduction as well, if possible?
Yeah, sure. So my name is Shaqil Kassam. I'm a medical oncologist just north of Toronto in Ontario, Canada. I'm a community medical oncologist. And I treat, like many other community oncologists, many tumor sites. My medical training actually started back at the University of Toronto, but prior to that, I actually did a master's in DNA repair and radiation biology. And so that sort of colored my sort of path going forward. I actually trained as a radiation oncologist for 2 years. And then as the internal medicine people say, I saw the light and did switch over to the internal medicine and then did medical oncology. So up here in Newmarket, I treat all thoracic malignancies, all GI malignancies, skin, and then I also do neuroendocrine tumors. And, patients who want to be closer to home with other tumor sites, I'll see them, such as head and neck and sarcoma. So, I think a true community practice, which is really exciting, but also very difficult to keep up with all of the data that is like drinking from a fire hose, as they say,
Of course.
Yeah. And Shaqil, what inspired you to pursue a career in medicine to start off?
I think it had to have been, as a child of South Asian, East African parents, it's sort of like you have three options, as a child as to what you want to do. It's either you be a doctor or you be a lawyer or you be an accountant, right? And so, and I'm not saying that's the reason why, but I think you always have that, or I had that thought in my brain. And then as I was training, in high school, I really enjoyed the life sciences, biology, and specifically physics. And I pursued that through my undergrad. And I really enjoyed, actually I did a minor in physics, or I got close to doing a minor in physics. And then that sort of colored me to do radiation biology. And that's when I really saw the molecular aspects of oncology, how what we do, where we are, where we sit, and what is irradiating us can really affect what we do. And so clearly, I think I was hoping to get into oncology, which I did. Initially, it was radiation, but in medical oncology, it's way more interesting in the sense that there's so many different treatments that we can give now to patients, right? So that's sort of my path forward.
Okay, excellent. And, we hear a lot about, community oncology, the academic. Could you kind of help us understand what the difference is? What's the difference between you and as a community oncologist and an academic oncologist?
Yeah, totally. I think it's, the way I see it, right? The academic oncologists have a lot of responsibilities in addition to their clinical work, right? And I think for those oncologists, or really any academic physician, it's not only just seeing patients, and they see a lot of patients, they also are responsible to be productive in terms of research, in terms of education, and also to be productive in getting grants and funding those researchers, right? And I think because of that, a lot of the academic oncologists really treat, one, maybe two sites that are usually related. And that makes sense, right? They see that same tumor type and they can accrue to those trials. I think also, so that's one big difference. I think the other one is that sometimes the resources are a little bit more pronounced in academic settings. The fundraising and the foundational support that occurs and is very important in the Canadian healthcare system, goes to the big academic centers, and rightly so, because that's where the research is happening. So I think resources for community oncologists are a bit different. In terms of tumor sites, as you can see, I treat a lot like many of our community medical oncologists. And, we don't have much in terms of fellows and residents. So we're running those clinics and then trying to keep on top of multiple tumor sites becomes difficult, right? So I think academics definitely have a lot of things pulling them in different ways. And equally, community medical oncologists have different tumor types, and staying on top of those, keep pulling them in different ways. And also the resources, as I mentioned before, is somewhat more limited in the sense that it's us running the clinics usually and trying to get these patients through. So there are those kinds of differences. And I think the final thing I would add, when the trials are designed and the molecules are investigated, especially when they're mostly done in academic settings or the studies are designed in those spaces, it's designed in the context of those centers. And some of these things are not necessarily feasible in an outpatient setting, in a community outpatient setting. And for example, bispecific therapies, those were designed to be as an inpatient administration, and they're excellent. The efficacy for tarlatamab in small cell is unprecedented, unseen, and I wonder if we'll ever see anything that is as dramatic. However, that's inpatient, right? And a lot of community sites could not initially and still have not been able to administer those drugs. And I think those kinds of things need to be contemplated when trials are being designed. So those are sort of the differences between the two as I see it, but they do very much bleed into each other,
Yeah. And do you is there a percentage, like 80% of patients are treated in a community setting versus 20 in an academic setting, or do you know? Does anyone know?
I don't know. I wouldn't have those numbers, but I would guess that, if you look at just the sheer number of academics versus community, I would say it's probably around that, right?
Yeah.
80 versus 20. If you just look at, I guess how many oncologists work in the academic settings versus the community settings, I would argue it's around that number. That being said, I think the patient population that is seen in academics is completely different, right? Because most of those patients are being referred for a clinical trial, and they're likely either very aggressive histology or have progressed on multiple lines of treatments. So, perhaps they're seeing the same number of patients or maybe a few less, but those patients are usually high acuity because they've been either heavily pretreated or they're looking for alternative options for their treatments. So I think it is 80-20, but the workload is probably, definitely equal in the sense of that, the complexity of the patients that we see. And arguably, because the academic settings are also overrun with patients in the Canadian public healthcare system, a lot of those complex cases are also being seen at our center. And so patients are living longer, which is excellent, but then the complications, the toxicities also add on to that complexity.
Okay. Do you have a network of people you can contact around, complex toxicities or anything like that?
So we're really, really lucky that I think in Ontario and actually nationwide, we are able to contact people via email, text, or phone. And our academic colleagues are so agreeable and also so available, to talk about toxicities, because I think they also understand that, they've probably seen these drugs in trials, several times more than we have. And then we all learn together, right? So the first call is probably the biggest and the longest. And as we see more toxicities, it's sort of like we all learn together. And so that's really, really important. And it's great that we have that collaboration.
Excellent.
Very good. Just on to the podcast that you've created, could you just, the MedOncNow podcast, could you just go through what the primary objective and what inspired you to kind of get involved or get it started?
Yeah, so I think it was like 5 years ago or so, Merck actually came to me and they said, this podcast thing seems to be catching on. It's like, this internet thing is looking great. And so like, you seem to talk a lot. It's like, what are your thoughts on a podcast? And I'm like, yeah, I had never actually thought about it. But then as we sat and I was like, well, what is the unmet need and where could a community oncologist like me provide benefit to other community oncologists, and how do we get people to listen, right? Who am I, for people to listen to me? But I and my colleagues all turn to key opinion leaders in the field on how to, treat patients and deal with the side effects. And the way that funding and access to drugs occur in Canada, and especially the fact that these drugs are becoming available and are more targeted, there are several drugs that nobody in the community setting would have given and only the academic centers would. So when we get access, whether that is through a PSP or exceptional access or full funding, we now have access to this drug, but many of us may not understand or feel comfortable making the decision as to how we sequence it and how we deal with the toxicity. So the whole point of the podcast was, and is still, to talk about new drugs with new indications that have not been in the Canadian landscape before, or old drugs or old molecules in new settings that we have not given before. And the whole goal of the podcast is that if it meets those criteria, so new and a new indication or new into clinic, or an old drug with a new indication, and there is widely available access to the Canadian population, then we will do a podcast on that topic. And so what widely accessible access means is that either it's a compassionate program, fully compassionate, not looking for insurance or self-pay options. Those would not be included because that is by far the minority in the Canadian population. Or if there is an exceptional access program, or if there's full funding. And so if there are wide access to the Canadian population, not based on the ability to pay or have insurance, and it meets all of those criteria, so new indication, new drug, and wide access, we'll do a podcast specifically focusing on not the numbers and the hazard ratios, but it's really about sequencing which patient population, what biomarkers are you using, and what toxicities should we be looking at, and how do we manage them.
Excellent.
So it's practical implementation of new treatments options.
Yeah. And you mentioned there, you're like, I suppose, obviously in Canada, you're focusing on Canada, but obviously the information you're discussing is worldwide. It's applicable worldwide. Are you seeing that in terms of listenership?
Yeah, definitely. So, we've had a couple of changes in platforms, but our previous platform that I was using would actually tell us where people were listening to. And remarkably, when we first started about 5 years ago, you would see that, I think 70% of our listenership was North America, mostly from Canada, but there was also people from the UK, from Greece, and then it was sort of, working its way through Central Europe, Western Europe, and then in Asia. But then that platform went bankrupt, so we lost all that data, and we moved to a new one. I don't get that kind of granularity, but clearly that was the trend. And now that we've sort of we've affiliated with Oncology Education, which is a Canadian education platform. They're helping us sort of bring awareness of the podcast. And so I'm still creating it, but they're sort of advertising it for us. And we're seeing that there is also that Canadian, North American, global reach to the podcast as well, which is excellent because I think all of us are suffering with the same issues of sequencing and toxicity management for new drugs.
Yeah.
Yeah, I can imagine. Yeah, definitely. Yeah.
Just moving on to, beyond the podcast, how do you see the field of oncology evolving in a country like Canada over the next few years?
It's as these drugs become and are very expensive, and it's not just oncology, in a publicly funded healthcare system, I think the issues that we're facing is how do we get drug to patients faster, And I can see that the government now in Ontario, and I think internationally, is really focusing on trying to get the approvals expedited and to get drugs to patients, even perhaps while negotiations are still occurring. And I think that's the biggest issue. First of all, is access. And that's everywhere, maybe aside from the US and some Asian countries. I think that is a big issue in terms of access. The second issue is the complexity of the treatments themselves, right? The pendulum always swings. We've got toxic chemotherapy, great. We've got these molecules now that are less toxic. Now let's intensify and make them, more toxic again. And inpatient administration, long infusion time in the chair, repeated and multiple appointments to the cancer center stresses both patients and the healthcare system. So I think we are all, dealing, globally and especially in Canada, about how to reconcile all these issues, because we've got all these great drugs, some of which given unprecedented outcomes, but then how do we allocate them and make sure there's equal access while making sure that healthcare in general doesn't break, in our institutions and country. So I think that's where we're going, but we're seeing great new advances in ADCs and bispecifics and radionuclide therapy, immuno-oncology with, chimeric antigen, T-cell antigens, and, we're seeing more bispecifics. All of this is great. We just have to make sure that when the trials are designed, that they keep in mind that a majority of patients are treated outside of resource-rich centers,
Yeah. There's so many options.
Yeah.
Yeah, I suppose it's difficult to stratify those patients into those, like what the options are to prescribe to that patient. It's just very tough for you and the community as a whole, I'd imagine.
Yeah, I agree. Like everybody's trying to go for the same line of therapy. So, then they all publish at the same times. And now you've got 3 drugs attacking the same molecule in the same line of setting, all slightly different, in some way, whether it's the toxicity or the inclusion criteria. And then you're like, oh my goodness. So now how do we choose? Right. And that's hopefully what this podcast fills that space.
Yeah, of course. And is there anything you think that has, that Canada has done particularly well that could be adopted elsewhere in the world?
I think we very much focus on equity, amongst our population. I think a lot of us feel that is probably the most important thing. And so I think that as we as oncologists understand that we can't have everything for everyone, and we want what the patient needs, what is the best in their interest for as many patients as possible. And yes, sometimes that sacrifices time as the negotiations occur, but ultimately when we get them, I think that equity is the biggest piece, and that's what I really do like about our system. Yes, it's slow, but every healthcare system is slow. And I think with people like our academic institutions where we've got international leaders, leading these global multinational trials, it really gives us access and our patients access to drugs. So I think that combination really is good for oncology care in Canada.
Okay, great.
Very good. Just moving on. So what do you see as some of the key challenges or barriers to global cancer care?
I think it's exactly what I was saying, the equity piece, right? I think there's large swaths of the globe that don't have access and probably never will, right? If you look at just the inclusion criteria and the countries that are participating in these trials, Africa in general is completely excluded, in many of them. South America, I think, is also underrepresented, some Eastern European nations, I think. So I think equity and equitable access to these drugs to everybody is difficult. I think the other thing is that, even if there was access, implementation due to some of the toxicities and the requirements that are needed for these infusions or these treatments are difficult as well. So, I think it's just that equitable piece that I don't really think there is an answer to, unfortunately. And I think that's the biggest issue. I think diagnostics is an issue internationally, availability to biomarkers, not only just the drug, but the ability to diagnose a target is lacking equity across the globe. And I think those things are unfortunate. And I'm people smarter than me will need to try to figure that out.
Yeah, it's a big undertaking.
Yeah.
Going back to yourself and your experience in your career, has there been anyone like any mentors or anyone you've worked with over the years that's kind of inspired you?
There's actually quite a few. Training at U of T here in Toronto, you get access to international experts and leaders, right? And it's just funny how you get to interact with the people in residency, and then you go to conferences and you see them all presenting, in the large plenary sessions, right? So I think the biggest one was, and when I was in radiation oncology, Rob Bristow, he's a radiation oncologist here in Canada. I think he moved to the UK and is or was leading the research charge there as well. He had a wet lab. I think he actually had 2 when he was here. And so he accepted me to do, some basic science research in his lab for about 2 years that I was in radiation oncology. And not only just that sort of interplay between clinical work and basic science work, but just, the advice that, you get just by chatting for a couple of minutes over coffee and, where the world is going, was invaluable, right? Like, I think, that was one big one. The other ones, Dr. Ian Tannick, I didn't have much interaction with him. He was a research advisor just in general doing medical oncology, but just the way of thinking and critically analyzing clinical trials, I think it is a mindset that I'll never lose. And then, Dr. Lale, Dr. Knox, all of these PMH treaters that, are just readily available to help whenever. So I would say there's not necessarily just one person or one group that has influenced me. It's the fact that we have access to these experts that we're influenced daily and weekly and monthly, so it's just a constant evolution of learning, which is amazing. To be able to learn new things all the time from smart people is a blessing.
Yeah. I'd be curious about the clinical trials. Like, how did he critically analyze them, or
I think it was looking at the minutiae. And I think the big thing, I think, is like there's a lot hidden in the supplement. You know what I mean? Like what you read in that 7-page article, there's a lot that if you really look into it, there is stuff there that really gives you a better flavor as to what that trial was, who was excluded, and just looking at some of the things like the consort diagram, the patient flow, why were patients excluded, how do they define PFS, how do they define this toxicity. I think all of those things really help you really understand. And so when I'm preparing for the podcast, and this is why it takes so long, is that because of that, I read the primary articles, but then also get into the supplement to see if there's anything that really we should know, right? These patients were excluded from this trial, which was not noted in the thing, and that makes up 30% of our patients. What do we do with that? These kinds of things. So that was really important. And then also understanding to be critical, because it really is really important to critically analyze the data that we're digesting.
Yeah, brilliant. That's really helpful. Thank you.
What are your thoughts on the role and impact of AI in medicine, and particularly oncology, I suppose, from your perspective?
Our colleagues, some of my colleagues are already using it in clinic in the sense of helping with administrative burden, right? So, they're using AI to help with their dictations. And I think the biggest issue that all of us are suffering with is that we go see a patient, that takes 10 to 15 minutes. Then you have to go back, do the orders, and at the same time dictate a note. You get 10 minutes to see a patient, but the actual interaction takes 25. So if you just do that math, by 10 a.m., you're already 3 hours behind, right? It's just that because every patient is longer than you have booked with them. So AI is already helping some oncologists where they go in and the AI is listening clearly with patient consent and confidentiality. And by the time they get back to their desk, the note is already transcribed, and they've taken the pieces from, I guess, the dictation or at least the interaction, and the note is populated. I don't know if it's pulling in all of the other data sets, lab work, pathology, DI, but just the dictation part, the patient interaction part is huge. I think that's the first. I think the second thing that we've already seen in oncology, if you look at this thing, the NMR, when it came to Dato-DXd, right? There's a TROP2 ADC where, it was thought that perhaps the staining of TROP2 on the outside of the cells was the most important thing to predict efficacy as a predictive biomarker. And it actually turns out the percentage of TROP2 inside the cytoplasm is more important. And that was detected, I think, by AI, as I understand it. But not only that, like AI, the way that you determine how much TROP2 is on the outside compared to the inside of the cell is a digital pathological thing, right? It's not a human that can differentiate between the staining on the outside and give a number and the staining on the inside and give us a ratio. That is all AI, right? I do know for the last 4 or 5 years, actually, there have been a lot of companies using AI to diagnose skin lesions. You take a picture on your smartphone. My smartphone is not that smart. It is a pretty crappy smartphone, so I think it would misdiagnose me regardless because my camera is so poor. But it would say something like, oh, your risk of malignancy here is quite high, and the program itself would initiate a referral to the appropriate people. I think there's going to be a lot more AI in pathology and DI. I think in terms of patient interaction and treatment decision making, I think AI can help us compare and contrast studies, quickly delineate the differences in the inclusion and exclusion criteria so we can understand, the patient really wasn't a candidate for this trial. But again, that whole aspect of, is it legitimate? Is it correct? Yeah. And is the report coming out of the generative AI program biased in any way? And the problem is that unless you know the data perfectly and exactly, you'll never pick up on a small error that might impair the judgment you're making. So that is my concern about it in terms of patient interaction and treatment decision making. But I think the things that are just like, is this a cancer cell or not? Is that tumor growing or not? Is this really progression or is it pseudo progression? I think these are things that AI can very much help with, with data in, data out kind of thing.
Yeah. Okay.
Final question. What advice or words of wisdom would you offer to individuals who are considering a career in oncology?
It's super exciting. I think if you like to learn new things almost on a daily basis, if you like to interact with people and other oncologists who are so generous with their time, even though they don't have a lot of it because they're so busy as our academic colleagues, I think our community in Canada as oncologists is so excellent because we help each other, but also we're treating patients and really make dramatic improvements with drugs that are just fascinating to understand and to treat. It is super exciting. But it is busy and there's really no time, but it's really exciting feel and it's interesting.
Yeah. Great. Well, thank you very much, Dr. Kassam. That was really very, very, very interesting conversation. Thanks for sharing your thoughts with us, and I'm sure our audience enjoyed the conversation as much as we did.
Thank you so much. It was a pleasure for me as well. Have a great day.
Thanks. Thank you to everyone for joining us and listening to the podcast. We will see you on the next one. Cheers.